Welcome. Can I remind members that the meetings are held in public session, and please to turn off your phones or Blackberries. I've had no apologies. Members have any apologies? Please submit them now. Under Chairperson's business, can I just remind members that next Wednesday the committee will be attending the NICON conference in Belfast, and if any members have not let the committee office know about their attendance, if they could do so as soon as possible. I also want to advise members that the Department has forwarded a response to the committee's review on health inequalities experienced by people with learning disabilities. We felt that Assembly staff will be attending a conference on the 7th of March on learning disability and health improvements, and that we would defer considering the matter until our meeting on the 12th of March. So that the clerk can feed back on what was discussed at the conference. So if members are comfortable enough to note that. Referring members to an email at page 4 of the tabled papers from Sean Rogers, MLA, regarding the reduction in opening hours at the emergency department at Down Hospital. The committee has advised Down Council that it could not become involved in campaigning for individual facilities or hospitals, and that it is our local MLAs and councillors to pursue these issues. It is important, members, that as a committee we stick to that position. The committee does have a very heavy workload, and we simply wouldn't have the capacity to meet as committees with local councils. We do apply this policy with all councils, so we're not and can't be accused of showing any bias. And this, of course, members, does not prevent any individual MLAs, constituency MLAs, to convene meetings around specific constituency topics in their own council area and in their own capacity. So I'm suggesting, members, that we write back to Mr Rogers and restate the committee position. Jim.
Madam Chair, following the deputation from Omagh Council last week, I would suggest that individual MLAs will be arranging some form of opportunity for Down Council to come up and lobby us on that, but that would be outside this committee.
I think, again, that would be down to individual MLAs to facilitate those discussions. Thank you for that. Moving on to the draft minutes of the meeting on Wednesday, the 19th of February. Referring members to the draft minutes held on the 19th of February, which are page 8. Can I ask if members are content to note? Okay. Item 4 is a review of waiting times in an evidence session. We're just waiting on our guest. I want to refer members to the copy of the presentation which is on the tables. And I want to welcome Professor Luigi Cicilline, Professor of Economics, Department of Economics and Related Studies at the University of York. You're very welcome. The procedure here is that we would ask you to make a 10-minute presentation, and then we'll invite questions from members. So I'll hand over to yourself.
Thank you very much, Chairperson. So it's a pleasure to be here. So what I'll try to do in my 10 minutes is to try to give you an overview of policies on waiting times, on maximum waiting time policies on waiting times across the OECD countries, and then, time permitting, I'll discuss some waiting time measurement issues. So most of this draws from a review of policies I co-edited for the OECD. So I'll try to give you actually the headlines and give you a brief summary of the 300 pages report. So if you look across the OECD countries, the most common policies these days is a maximum waiting time policy. So that's what you see convergence across several countries, is that the way the policies develop is to specify a maximum. Now, the way the maximum then is specified and is used in the different countries can actually be quite different. And that's where I would like to identify 3 different groups. So the first one is where you can use a maximum waiting time as a target. This was the case in England and Finland, for example, so that providers that do not perform on the maximum and there are patients over that target, they receive some penalties. So that's one way to use the maximum. Other countries don't like that so much that approach, so they prefer to mix it with incentives that are more related to choice and competition, so that patients who go over the maximum, they are entitled to go and seek treatment to another public hospitals or maybe to a private hospitals, but at the expenses of the public system. So that's a quite different way to use the maximum waiting times, and this has been experimented in Denmark, Netherlands, and Portugal. Now, the last way to use the maximum waiting time is actually quite different. It is as a tool of prioritization. So this is not so much about the penalties and targets. It's just that the maximum waiting times is used as an indication of the patient severity. And countries like New Zealand and Canada and perhaps Norway, they have gone down this route. So the key focus being prioritization. The last thing I want to mention, just in general terms, is that there is also a general trend to differentiate maximum waiting time. So you maybe have a general maximum waiting times for all elective care, but you may have like some shorter ones for more urgent care, like cancer and heart conditions. So that's something I have observed across a range of countries. So in terms of sort of a key policy message that I would give from this review is that I think we know that supply policies are generally not necessarily successful to reduce waiting times because you increase the supply and possibly the demand maybe goes up by the same amount, so nothing happens on the waiting times. So what I've seen as a key ingredient of success is actually to combine the increase in supply with the maximum waiting times, so that this combination of the two is such that you increase the supply, but you keep the demand under control by the maximum, because you have the maximum that the demand cannot, then the referrals cannot go up so quickly. So from what I've seen, a key ingredient of success is the combination of increases in supply and maximum waiting times. In a few countries, this has led to quite substantive reductions in waiting times. So the rest of my few minutes, I'll go through some examples. So I think I'll go quite quickly through the English examples, because probably you're quite familiar with it. But England started with quite high waiting times in 2000, more than 200 days for a few elective procedures. And then the targets were introduced, more resources were put into the system, and waiting times went down quite rapidly from more than 200 days, maybe to 50 days for some elective procedures like hip replacement. And I think the one key issue with these maximum waiting times is the potential for misprioritization. And I think this is a point that doctors do make quite often, is that, well, one potential problem with maximum waiting time is that this really applies to the low severity patients who, if you have a system which has prioritization, are the ones that tend to have lower severity. So potentially you could have that this maximum waiting times applies to the low severity patients at the cost of some relatively higher severity patients that are waiting relatively longer. And maybe there is some evidence that this behavior is happening. Now, Finland also had a similar experience, so they introduced the maximum waiting times targets. In 2000, they had very long waiting times, similar to the English ones. And they managed to also reduce down, to bring down waiting times. And this was, again, a combination of extra resources with a healthcare guarantee, which specified the maximum of how much the patients should wait. Now, I'm going to move to the second type of policies that involve more choice. So that has been experimented for a few years in Denmark. So in Denmark, they said, okay, the patient, if they wait longer than a certain time, they can go, for example, to a private hospital. And that seems to have contributed to some reductions in waiting time. One policy I really would like to mention is the Netherlands, because if you look at the change between 2000 and 2010, there have been some quite dramatic reduction in waiting times. So in 2000, we had like on average 15 weeks waiting times for a few elective procedures. And now in 2010, this is only 5 weeks. So the waiting times have gone down quite a lot. So how did they do it? So on one hand, they also introduced some maximum waiting times. They didn't call it a maximum waiting time. They preferred the terminology of socially acceptable waiting time, which specified a maximum, for example, for inpatient treatment of 7 weeks, combined to another rule that said that 80% should be treated within 5 weeks. So again, this is actually an alternative way to specify the maximum, that you set the maximum for everyone, but you say, well, actually a proportion of the patients actually have to be treated in a shorter time, so that you tackle to some extent the issue of misprioritization, and the focus on the low severity patients is lessened. But in the Netherlands, I think that was not the only reason for the reduction in waiting times. I think only introducing a maximum waiting time would not have been so successful if the government at the same time wouldn't have relaxed the capacity constraints. And in fact, hospitals changed from fixed budget to activity-based payments in 2000. Specialist remuneration also changed from lump sum payments to sort of fee-for-service type of patients. So all of this contributed to increase the volume. And these days, policymakers are actually not concerned anymore about waiting times, but their main concern is the sharp rise in health expenditure. So you can see that sometimes you have big trade-offs there. You can solve some problems, that's good. Waiting times can go down, but sometimes at the cost of a significantly higher expenditure. Okay, so the third point, the third type of policy that I wanted to mention was to use waiting time as a prioritization tool. So if you look at the New Zealand experience, I think here is quite interesting. So they basically have 3 different groups. So the patient can be either booked straight away or receive a certainty of treatment. They will be sure that they will be treated within 6 months, or they can be put back in active care and review, which basically means that the patient is sent back to the family doctor, and the family doctor will check on those patients. So there is this idea that some patients maybe shouldn't be put on the waiting list. If they are really on the low severity spectrum, they should be sent back to the family doctor. So this is more like a demand management sort of policy. It's quite different policy. And the way also the government tried to facilitate this policy was through the development of some prioritization tool. And just to be quite practical, I've tried to give an example of how these prioritization tools look in practice. So if you take hip replacement, there would be like a form that would say, well, what is the pain in motion for the patient, what is the pain at rest, and each of these groups has a score attached to it, so that this gives you like a severity index. So this could be like some formalized guidelines, tools that could facilitate prioritization, and is linked to the formulation of a maximum waiting time. The last policy I really want to mention is the one in Norway, which really uses waiting times as a prioritization tool, in the sense that every patient is entitled to an individualized maximum waiting time. So this is quite different from the maximum waiting time policy we normally observe in England or in Finland. Here, basically, the specialist sees the patient, and based on the severity, decides that that patient has a maximum waiting time of 6 months. Then the following patients comes in, and based on their severity, decides that it maybe is 3 months. So this is an individualized maximum waiting time. So what I would say about those policies is that those policies solve the prioritization potential problem that the unconditional maximum waiting times have, but on the other hand, perhaps they introduce too much discretion in the system. And the early evidence on the evaluation of the Norwegian policy is that perhaps this policy didn't change dramatically waiting times in any way. So that completes my overview. So again, I've tried to give you an overview of what policies have been going on maximum waiting times, and distinguished between the 3 main types, which is either you use it as a target, or you combine it with choice and perhaps some involvement of the private sector, or you use it as a tool to prioritization. I have some other issues to discuss on measurement issues, but I wonder whether I should pause here in case there are some questions.
Well, thank you very much for that. I suppose just a number of questions I would have. Is it, whilst we have been conducting this piece of work, we're continuously told that we need to look at the complete patient journey and not just a part of it. Would that be your sense of this issue as well, that almost from the patient is referred for treatment right throughout the patient's journey?
Yeah, so it seems to me that based on what the current evidence, that's a good idea in general, because I think several countries are moving towards the idea that you should follow the patient journeys. And one reason is so that you have a complete measure of waiting times, but this is just generally that you want to understand the patient path care better if you do that. So I think that seems a good idea to me, and some countries have moved in the direction of measuring the referral to treatment. But this is still early days in the sense that we have England that has referral to treatment. We have Denmark that also has done referral treatment. So we don't have too many countries to draw on their own experience to be able to benefit and see whether this worked well or not. What I can observe from the English experience is that there are some complications that arise from a referral to treatment, which is that you need to report at least 3 different types of measurement. So normally in England you have the admitted pathway, the non-admitted pathway, and you have the patients that are on the waiting list or the patients that are treated. So this brings a bit into the measurement issues. So if you think about waiting times, there are 2 main ways to measure this. One is you take a snapshot of the patients on the list and check how long they have been waiting, or you check all the patients that were treated in a given month, let's say, how long have they been waiting. So that's already 2 different measures, and there are benefits and disadvantages for each of these 2 measures, and possibly a good idea would be to have both of them. Now, if you put that idea in the context of referral to treatments, actually, if you look at the incomplete, the snapshot measure, you actually don't know whether the patient is going to be admitted or not admitted. So that patients on the list will be a mix of the 2 distributions. While for the patients that have been treated, then you will know that whether that episode finished with a treatment in the hospitals, or maybe the patient just saw the specialist and then they didn't need a surgery. So you can see that there are the idea of referral to treatment is interesting because it covers the patient journey, but it brings in some extra complications, which means that in practice you may need at least 3 different measures of waiting times.
Okay. And would it be your view that there needs to be a separation of waiting lists and waiting times, that they're 2 separate?
So I think there are different orders of measurements. So the very basic distinction is between waiting time and waiting list. So the waiting list is just the numbers waiting. I think possibly policymakers have moved away a little bit from just counting the number of patients on the list, but perhaps, maybe if I misunderstood what you were suggesting, is to measure the waiting times of the patients on the list. So I think that's where you have benefits and disadvantages from measuring that one. So if you measure the waiting times of the patients on the list, you have a reasonably accurate and responsive measure of what's going on in the system at that time, because they are the patients on the list at that time, and you check the distribution, you can check the average. That's quite useful, could be useful for monitoring purposes. But on the other hand, it measures the incomplete waiting times, because by definition, the patients who are on the list, they are still waiting. So you don't have the full measurement of how long the journey has been. And that's where the other measure is really useful, so that if you have the average waiting times of the patients that were treated within a given month, then you have completed the journey, and that's a more accurate reflection of the patient journey. But it happens with a delay, because the patients now were treated, your measure is actually of patients that were treated in the past. So you don't have like a very accurate measure of what's going on the patients at that point in time. So in that sense, I think that there is scope for measuring both of them, both measures, because they capture slightly different dimensions. Yeah.
Okay, and then finally, just in some of the detail you've given us of a decrease or positive impact on waiting lists and waiting times, has there been any analysis of that impact on health outcomes or even economic outcomes in relation to health?
Yeah. So I think that there has been some research that tries to test, is it the case that patients who wait longer, they have worse health outcomes? In my assessment, this literature is not huge, it's still a little bit preliminary. What I'm aware of is that there has been some studies, mainly from Canada, that tried to test whether patients who had longer waiting times and that they were waiting for a coronary bypass, whether this affected their health outcomes. And this study seems to suggest that while they were waiting, patients were more likely to die, or maybe they had a higher chance of having an emergency readmission. So for coronary bypass, there seems to be evidence that goes in that direction. Then there is some other evidence that is more of the orthopedics department, so for hip replacement, for example. And there the evidence seems to be slightly more optimistic in the sense that longer waiting times do not affect so much how much in pain is the patient. So if the patient waits 6 months or 3 months, the condition doesn't get worse so much as time passes. So that's my reading of the evidence, and these are the two primary examples that I were able to identify.
Okay, thank you for that. I have Kieran.
Yeah, Chair, thanks very much. Thanks very much for your presentation. Are we talking about specifically, are we omitting the accident and emergency? We are omitting.
So far, I have omitted access and emergency in the sense that, the primary focus of my review has been on elective. So it's really on the long waiting time patients. So in my reading of the literature, I think the issues that you have on waiting times for access and emergency are quite distinct and different from the long elective waiting times patients. So all I've said really applies. You're right that it applies to the elective.
Well, we could keep you here all day talking about accident and emergency, but you haven't gone down that road. I simply want to know what is the most important aspect of treatment times that we should be seeking to measure in order to get an accurate view of performance?
So I would say that the referral to treatment waiting times seems to me like a good way to do it, in the sense that it captures the full journey, and I would capture those three distributions. I think once you have those three, I don't see why you should go somewhere else or try to seek other data collection. I think maybe one thing to keep in mind is how you want to do that data collection, in the sense that ideally it would be nice to do that data collection from existing sources so that you don't have to reinvent a new data collection. But I think actually my understanding of the English data collection is that this is a separate one, so that they actually did a new one for the RTT.
Right. Well, the next question was, is there a critical mass of societies that are measuring referral to treatment times? And you would say there is.
Okay, so at the moment, the only two countries that really are doing this is Denmark and the UK or England, and the other countries are not measuring the referral to treatment. So I think this is because we're still in the early days, and I think people like the idea of measuring the patient journey. It's just that traditionally, the traditional measures of waiting times have been the other two, and actually each country, they even have many countries, they have chosen either one or the other. So in the sense, they all focus on inpatient waiting times, and they either measure the patients on the list or the patients treated. So there is lots of heterogeneity, and hopefully over time we will converge to the referral to treatment.
Okay, thanks, Chair. Thank you.
Thank you. I have Jim next.
The stats are very interesting, and obviously the UK doesn't come out very well in your analysis, and I suspect that Northern Ireland within the UK is probably even less impressive. But I mean, you're quoting countries here like Norway, Netherlands and Denmark, all very wealthy countries who allocate a huge proportion of their income towards social welfare and health treatment. You have extraordinarily good English, but have you ever heard the phrase, we cannot comparing apples with oranges here? I mean, if you throw enough money at the problem, presumably in the Danish situation where tax rates start at 40%, well, presumably you have enough money to have a good waiting time programme.
I can see your point, but actually you could think that the Nordic countries, which really spend all the public budgets are quite high, actually there shouldn't be no waiting times at all. So, in fact, it's perhaps surprising that even countries like Norway or Denmark, actually, they do have significant waiting times. So I think some of those countries have been successful, but countries even like the Netherlands, they had a significant problem there. And it's true that they put quite a lot of extra resources, but now even the policymakers themselves, they're saying, okay, well, actually, health expenditure is going up too quickly, and it could be that they're going to scale it back. So I think many countries are struggling with the waiting time problem, and it's not all about income and how rich the country is.
I was intrigued by your comment in some countries that if you can't get the hip replacement or whatever done within the appropriate target, you have a right to go to a private provider, get the work done and bill the health service. That was a nugget of information in the middle of your presentation. Can you give us a little bit more detail about it? Because that's quite revolutionary what you're saying there.
Yeah. So I think that's the Danish experience, and perhaps I should qualify a little bit better that policy. So the patient, after the maximum, they are entitled either to treatment in another public hospitals, maybe in a different region, or to the private sector. So in practice, the number of patients who really choose to do that is not massive. So in a way, although the policy states that that's the case, in practice, it's not that there was. There was some increases in the private sector involvement, but still we're not talking about huge, massive increase in the private sector involvements. And if you think also about the English experience where they brought in the independent sector, the dependent sector can do 5% of extra elective procedures on hip replacement. So I think the private sector involvement is one ingredient in these policies. But I wouldn't say that it is really the critical, it doesn't have the critical mass to be the really contributing factors that really manage to reduce the waiting time so much, even in Denmark or the Netherlands.
Yeah, but of course the model here is different. The patient doesn't have the choice. If the health trust finds that the wait is too long, they can commission the private sector to carry out a number of procedures. Indeed, in Northern Ireland, we actually allocate procedures to hospitals in the Irish Republic, and people will go down to Dublin or Athlone and get work done. What's so radically different about this is that once a certain date passes, the patient has a right to knock the door and say, I demand this to be done. Does that then concentrate the minds of the trusts, the health trusts or the equivalent, in the sense that presumably they don't want to pick up that bill and therefore, as it's more expensive, they try and stay within their limits?
Yeah, that was the intention of the policy, in the sense that I think the government had the hope that this would have a disciplining effect, so that the initiating hospitals or local authorities would try to stay within the maximum waiting time, so that this would not happen so much. And I think Portugal kind of followed a similar idea and route, although it's not listed in my presentation, and you will have another presentation later on in the next month. But again, in practice, I think that actually works maybe as a threat. But if you look at the numbers, there is still not a huge number of patients who actually exercise that choice. So it's a combination of factors. So. And I would say that with the private sector, if you allow me, there is always this choice of how should you structure the involvement of the private sector. So do you just try to involve the private sector and say, can you do this extra elective care? Or could you actually use the same resources for the public hospitals and ask the doctors working in the public hospitals to do that extra volume? So I think there are some different policy options here, which maybe in the bigger picture they could at some point be equivalent, in the sense that you have some extra resources, you can give it to the private sector, or that private sector potentially may recruit the same doctors working in the public hospitals, or you could have that public hospitals with the public doctors who says, well, can you do some extra sessions and we'll put some extra resources on the table. So,
is there evidence that having a high-quality procedure service with short waiting times actually generates more work? In other words, if people perceive that there will be a short time, like for instance in the Netherlands, which is an extremely good performer, does that in fact just cause more work because GPs and patients are more likely to demand that type of surgery rather than just making do?
Yeah, so I think that tension is always there with waiting times, that when you expand the supply, then your primary concern is that demand is going to grow up, and then you start to do the marginal care. But I think that's where this maximum waiting times policy come in the sense that you say, well, actually the maximum has to stay within those 5 weeks or 3 weeks or whatever it is set by the regulator, and that keeps the focus on keeping the referrals more limited. So otherwise, then the demand would go up, and then you wouldn't be able to have the short waiting time. So I think in that sense, I think this is the combination of this supply and maximum waiting times that help to keep the demand under control.
And finally, the only obvious question is, well, why does Italy not feature in any of this research? Since, why does Italy not feature?
Actually, Italy was covered in the review, but because Italy has 20 regions and there is quite a lot of heterogeneity within Italy, it was quite difficult to cover in my 10 minutes. So it is there, but it would need like a long digression.
Thank you.
Thank you. David?
Thanks very much, Chair. And thank you for your presentation. I mean, I think really just as maybe a prerequisite, I mean, obviously from our constituency point of view and the work that we're doing on a day-to-day basis, that person who is waiting for their hip replacement or their knee replacement or whatever it might be, it is hugely important to them. So I think this piece of work is really, really important. And I know a lot of the media focus is obviously around accident and emergency, but I think it would be wrong to ignore the suffering that people sort of quietly face on a day-to-day basis as they sort of creep very slowly up the waiting lists. I suppose you gave a very helpful overview of what different regions are doing. I wonder if I could perhaps try and encourage you maybe off the fence a little bit, with the greatest of respect I say that, and maybe give us an indication as to what you feel in your experience is working best.
Yeah. Okay. So I think again maybe I risk to repeat myself a little bit, but so I really see that combination of extra supply with maximum waiting times that really works best to make sure that these waiting times for the hip replacement and the knee replacement are brought down to acceptable levels. In the sense that many governments try to create that extra resources. How do we make sure that this just doesn't translate into the just extra referrals and the waiting times just don't change? I think it's that combination of. So I think now the evidence, after reading all these countries' reviews, that was really my main conclusion. If you combine the two, so in the past, most countries they would either act on one side or the other. So they would just say, well, let's increase supply and let's hope that the waiting times would go down, and this wouldn't happen. Or let's just say now patients, they just cannot wait more than 30 days, and then without explaining how this should happen, and that also wouldn't work. So to me, the key is really this, to understand that the waiting times is a demand and supply phenomenon, and to combine that extra supply that you can create in different ways, either by increasing the capacity in the public sector or maybe involving the private sector. These are alternative options, but the key is the demand, and to make sure that the demand of referrals does not respond so quickly to those reduction in waiting times. Because we hear stories that when waiting times reduce, then doctors have this tendency just to refer more. And that's the balance that has to be taken. So that's, to me, is the key to this.
So perhaps, Chair, I'll maybe reword the question. It's possibly the same question, maybe just in a different way. If the chairperson of this committee was asking you, where she should go and book a flight to, where would you be suggesting? In order to explore, obviously, where best practice is.
Yeah. I would actually go to the Netherlands, in the sense that that's where I really saw this happening, in the sense that the idea of the maximum waiting times, actually they didn't like that phrase of maximum waiting times. They actually started some discussions with the doctors. They brought all at the same table, and they said, okay, let's say what is really the reasonable maximum waiting times that patients should wait according to the medical ground. That seems like a good starting point. And then once they have determined that, then they said, okay, let's now bring the resources to bring it to that level, but then make sure that you stay at that level. So I would say actually that the Netherlands seems to be, yeah.
And in your research, is there any obvious societal differences between what is happening in the Netherlands and what happens in the UK? I suppose the point that I'm getting at is that, I think as my colleague has mentioned, you can pour money into things, but if the societal culture is not there to, I guess, change the way that they think as well, the public thinks, it obviously can result in almost kind of putting good money after bad money. Is there a cultural difference when it comes to attitude towards healthcare in the Netherlands that would differ from the United Kingdom?
So I would say that in the Nordic countries, maybe put the Netherlands as well, I think the way you do things is more by consensus. and nearly unanimity. And so really to bring everyone around the table and make sure that everyone agrees on the plan. I would say that maybe that's not always necessarily the case in other countries where it's more maybe top-down and say, like, actually, these are the targets and just go on with it. So I would say that that's a major cultural difference. Okay. Thank you. Thanks, Chair.
Okay, I have Roy next.
Again, thank you for your presentation. One of the areas where you've talked about that has been a considerable improvement has been, and it's in your handout here, has been New Zealand. And you can see quite a dramatic drop in their waiting times over a 1-year period. And the explanation given for that has been a mixture, and as you referred to this idea, a mixture of issues has brought about best results in certain areas. Increase in service delivery, review and part review of the waiting lists. Can you maybe tell me a little bit more about this review of the waiting list? You know, it's easy to remove someone who's already been treated. I mean, that's not non-controversial. But you also indicate that many patients who were also informed that they would not be assessed. So, I mean, how do they get on the waiting list if they don't need to be assessed? I mean, I'm just trying to understand how people would be removed without some sort of clinical assessment.
Yeah. So actually, I think that's a reasonably common phenomenon that I've observed in these different countries, that whenever the waiting list problem suddenly becomes more of a real policy concern, then the first thing that policymakers try to do is to make sure that the data are of good quality. And that's, I think, where this reviewing of the data happens. And I have an old paper where I have some very similar picture for England when they had the early initiatives on waiting times, where basically the waiting list data, they were not very good, in the sense that on that list there were also patients that were on other lists in other hospitals, or maybe some patients that already had received the treatment. So in a way, actually part of that reviewing the waiting list were really patients that were not supposed to be on those waiting lists, so that actually those were kind of inflating the waiting list for no reason, because that patients actually were not supposed to be there. So in that sense, what I've seen for a few countries is that whenever you try to make a jump in the quality of the data, you will always have that first review of the data, that suddenly the waiting list will have a drop, and then will stabilize, in the sense that once you have taken out all those patients that were not supposed to be on the waiting list, well, then they are gone. And and once the quality of the data then becomes acceptable, then those patients are never added to the waiting list. So you just have that one-off effect. So part of that drop is only partly due to that, but then there were other things going on at the same time, which was including a bit of increase in supply, maybe some patients sent back to inactive care review, and so that was just one of the ingredients of those.
I'm trying to see, for what other reasons people would be brought off their waiting list and returned to their GP. I know in terms of hip replacement, I recently came across a constituent who had been referred from his GP to a consultant. Part of the process is going through an ICAT centre in Northern Ireland. So we waited for a few months to go there. Having passed that and identified, yes, he does need a new hip, referred to the consultant, and there's a 6 months waiting list to see the consultant. Once he sees the consultant, there's then another 6 months waiting list for the operation. You're talking in your slide about New Zealand about numbers waiting 6 months for treatment. Is the definition of 6 months waiting for treatment the same everywhere? Because 6 months doesn't really mean anything to my constituent. He's waiting over a year.
Yeah. So, well, the New Zealand policy was 6 months to see the specialist and 6 months after to get the surgery. So, I mean, I don't know if that will answer your questions, but if you go, you mentioned initially the active care and review group, which I think is the most interesting for the New Zealand experience. So, if you go back on how this policy initiated and was introduced, basically what the government thought was that, well, there is like a clinical threshold over which patients can benefit from surgery, but then there is like an economic threshold. And those were the terms used in the policy document, and said, okay, ideally, potentially all those patients could benefit, and maybe these are 200 patients, but we actually have money for 100 patients to be treated. And that's where this active care and review group came in, so that it was the gap between what could be funded by the public system and afforded based on the revenues that are based on the funding, and what could be the patients that could potentially treat it. So in a way, it's a sort of rationalization of demand. So the idea was, rather than just adding patients on the waiting list and hope that at some point they're going to be treated, the idea was to make this demand management more explicit, so that some of those patients that you know that even if you put on the waiting list, they will never be treated, well, actually, let's send them back for active care and review to the family doctor. So that was the idea, which, I'm fascinated by this New Zealand policy because it looks quite different from any other policy I've seen in any other country. But that was a bit the idea.
Have they effectively significantly moved up the threshold at which point you get treated?
I think that actually this idea over time has evolved, and I don't think that actually that threshold has been operationalized in a very precise way. So I think, to answer your question, is this threshold is still informal in a way. It's just it is there, but it's not that it is precisely measured.
Final question, maybe. You said it's informal. Is it simply you're going to qualify if the money's there to allow you to get operated on, and then they will prioritise based on that, and if you're not in that priority, you're not on the list? Is it as simple as that?
Yeah. So the family doctor and the specialist, they have to work together and they have to prioritize. So the idea is precisely about prioritizing the patients early on, so that you kind of have a ranking of health or severity, and you basically use that information to decide which one are the patients that are entitled to the public treatment and which one are those that are not.
So it mightn't be a good area to look at. Okay.
Okay. Fergal?
Thank you, Chair. Just two consequence questions. In maximising the supply, and maximising the waiting time issue, are there financial implications? Does it cost more or less, or is it within budget? Or has the evidence shown that it's been within budget?
Sorry, I missed the first part of your question.
Just in terms of consequence, does your proposal for the best model effectively cost more or less?
I would say that the policies that have been successful in the sense that the waiting times have gone down, these were all accompanied by significant increase in resources. So definitely these are not policies that came for free. They probably implied significant extra amounts of expenditure. And possibly this was, most of these policies were in the early 2000 and onwards, when still the recession was not in. So I think in those times it was a little bit easier to provide those extra resources. Now that the recession is in, I think it's going to be maybe perhaps more difficult to implement similar type of policies because the budget is more constrained for everyone. So I would say that to replicate that idea, if you're starting at a higher level of waiting times, is going to be more difficult. So you can still try to experiment and say, well, we still introduce the maximum waiting times with not so much on expectations of an increase in supply, but it's going to be harder to obtain the reductions in waiting times.
And over time, has that cost stayed up?
Yeah, so I would say that the way to think about waiting times is in a dynamic, phenomenon. So actually, there is this idea sometimes in past policies that one way to reduce the waiting times or the waiting list is to introduce a one-off increase in supply, and that will make disappear. But that's doesn't work, because you need a steady increase, because otherwise for one period you have reduced the backlog, but then that tends to come back. So I would say that these policies are long-term policies with constant increases in expenditure. So it doesn't have to keep going every year. It's just like if you have an increase in supply, it's not a temporary increase in supply, it's a permanent increase in supply.
And just another consequence question: does the proposals that, as you've seen them, have they had any negative or positive impact in other waiting lists associated with the health service?
Yeah. So normally the policies that the more recent policy, they try to have policies that affect all elective care. So in that sense, they should cover quite a lot of the healthcare setting, which seems to be a good way to do it, because otherwise you would be concerned that if you focus on one subset, then other areas may suffer. Here the concern may be elective versus access and emergency, in the sense that you put focus on electives, and then these maybe may come at the cost of the access and emergency suffering. I'm not aware of evidence that support that, so I cannot really comment on that specific.
Okay, I just was wondering, would there be savings to be had elsewhere as a result of doing this, or additional cost imposed elsewhere as a result of doing this?
Yeah, I'm not aware. I'm not aware of any evidence that tried to look how that extra resources or that focus on the maximum waiting times could have diverted incentives in other areas. Yeah.
Okay, thank you.
Okay, Gordon.
Thanks, Chair. I think most of the points have been covered. Just, is there any evidence that the use of the private sector goes a long way to improve the waiting times?
I would say that the answer to that question is no, in the sense that that's just one complementary policy among others. So normally, I think the private sector is used in conjunction with a number of other policies that reinforce it. So I think so far, from what I've seen, actually there has been no policies that would only introduce the private sector. So it's a bit difficult to disentangle what is really due to the private sector compared to the other policy. But my overall impression is that the private sector was an ingredient and was one of the determinants that helped to the success of these policies, but was not perhaps the number one. I would say that the focus on the maximum waiting time was more important, and then the increase in supply could be obtained through the private sector, but could also be obtained in some other ways. Perhaps increasing the sessions, changing the contract for specialists and doctors working within the public sector. That could be another way. Building some new public hospitals. So these are alternative policies. So I don't necessarily see that it's the private sector in itself that is the one that dominates.
What about the internal processes within the existing services? Is that an issue that is worthwhile addressing?
So you're referring to the dual practice issue? Yeah. So I think that's an important issue that needs to be addressed, because I think for people who are in the health policy domain, they know that dual role of doctors generates a conflict of interest. So if you have, especially in relation to the waiting list, you know that if the waiting list is longer, then the patient is going to be more willing to go private if they can afford it. So in that sense, that conflict of interest is there. So
I think that's a real risk. It is a risk.
I think it is a risk, and I think you should think. Well, first of all, why is it the case that you want that dual practice to exist? So is it the case that maybe this is because then doctors are more willing to work in the public sector? So maybe it does bring other benefits. Do you really need that? Or maybe you could potentially change that element and say, well, actually, maybe doctors only work for the public sector. These are all policy options, but certainly there is a conflict of interest there. And that has to be taken into account when designing the policy. But I don't think there are any easy fix to that.
No easy answers?
No.
Great, thanks very much. Thanks, Chair.
Okay, thank you. Mickey?
Yeah, thanks for the presentation. Just on page 10 of your paper, you give example of prioritisation guideline, hip and knee replacement. It's in Western Canada. And they seem to actually deal with a person as opposed to the system. Because one of the things I've asked about pain and motion, if it's non-mild, moderate, severe, and then pain at rest, non-mild, moderate, severe, and ability to walk. So they actually seem to be looking at the person, how they're affected, as opposed to putting you into a system where you just become a statistic. And would that be the way that they're looking at it? Because if a person is in severe pain, obviously then they would be prioritised, presumably, because their mobility would be affected, their quality of life would be affected, all of that. And that seems to be actually looking as person-centred or patient-centred rather than just looking at numbers and statistics and all of that.
So let me say something a little bit more about those Canadian policies, which resemble a bit the New Zealand. So I think we know that prioritization informally goes on anyway, and the doctors are pretty good at doing prioritization. So I think the idea here about these policies was actually to develop a tool that would help the doctors to do something that they already knew a little bit how to do it. And it is correct that they put the patient in the center, And again, the way these guidelines were developed was was quite costly, because you basically had to bring together doctors, patients, members of the public. So about these guidelines, I would say that these are very interesting tools. They help the prioritization, but at the same time, if you are thinking about the large scale, they are quite costly potentially to develop, in the sense that we have one for hip replacement, we have 3 or 4 other ones, but these still cover just a small subset of the whole care. So I think these tools can help, but at the same time, there is a tension in the sense they're costly. So I cannot see necessarily this as the solution to the whole problem. Ideally, if this was costless, then this seems a good idea.
I suppose the point is, it is a solution for the patient. And if you don't have a system which is patient-centred, then it seems to me that you don't have a proper system in place. Because ultimately, if you're the person that's suffering severe pain because of you need a hip or knee replacement, you're not really interested in, somebody else's waiting list. You're worried about yourself and how you might be prioritised and how you might be dealt with. And it may be costly, but at least it's dealing with that particular person's problem. And that could be multiplied probably thousands of times. So it just seems a sensible way. Yep. And it is a tool, I accept that, but it's a sensible way of dealing with an increasing problem.
Yeah, I would just say, to complement what you said, is that maybe if you look even at the Dutch experience, this idea that when you determine the maximum, rather than just determine these maximum waiting times just based on a perspective, from a regulatory perspective, actually to that idea of having this maximum acceptable waiting times, which is really acceptable for the patient and maybe the society, seems a good way to go.
But when you talk to someone who has been waiting on a hip replacement and the severe and chronic pain they're in, and then talk to them after, it really enhances their quality of life. And, for older people particularly, as they may not have as many years left, to increase and enhance their quality of life seems to be a good thing. Thanks, Chair.
Okay, Professor, thank you very much for that. Just what I'm taking out of this is that you're suggesting that, well, there's not one quick solution or quick fix, but it's a combination of both extra supply or supply issue generally, which I expect would take in also issues like GP doctors' contracts as well, and workforce management, and then the maximum waiting times target. But I suppose for ourselves the issue becomes around enforcement of that as well, and maybe it might be just, as we conclude, get your thoughts on the best models of enforcement, because we can have all of the extra supply or maximum waiting times, but without proper models of enforcement.
Yeah. So I would say that in terms of enforcement, if you look at the key experiences that have been out there, I think the way to use really the maximum waiting times as targets and to really attach some very heavy penalties, like people losing their jobs, seems on one hand quite extreme enforcement. So that seems to be at really the end of one spectrum that perhaps is on the excessive side. So on the other hand, you do need enforcement. So possibly the current RTT policy, where part of the revenues are retained if you don't satisfy the maximum waiting time targets, seems to me like a compromise between having an enforcement mechanism that you need to have, otherwise without enforcement, the changes are not going to happen, but at the same time is not as radical as the extreme fines that were put in place earlier on. So I would say maybe attaching some serious financial incentives to the maximum waiting times seems to me like a reasonably compromise to have an enforcement that is reasonably balanced.
Okay, thank you for that. And I suppose by way of conclusion, just to thank you for taking the time. It's been very informative. Obviously, this is an ongoing piece of work. The committee feel, as does the wider community, feel very strongly about. I would actually just take the opportunity to suggest to you that as we develop our draft report into waiting times, that we maybe feed that back to yourself for your thoughts.
would be a
I think
pleasure.
that would be okay. That's great. We're going to take that we can forward that to you then, and you can feed your thoughts in. So I want to thank you and safe journey home again. Thanks for your time.
Thank you.
Today.
It was a
Thank you.
pleasure to be here.
Thank you. Okay, members, moving on to item 5 is the review of transforming your care and older people supported living. We have an evidence session now with the department officials. I want to refer members to the briefing paper on page 14, and there's also a briefing paper from Age NI at page 6 of your tabled papers. Okay, you're all very welcome. We have just from my list here, we have Sean Holland, Deputy Secretary, Social Services Policy Group in the Department, Mr Dean Looney, Community Care Director at the Department, Pamela McCready, Director of Transforming Your Care at the Health Board, and Mr Kevin Keenan, Assistant Director of Social Services, Older People and Adults at the Health Board. I just want to advise the witnesses at this point that this is the committee's first evidence session on the review into supported living, specifically obviously for older people and the wider context of transforming your care. So our purpose today is to gather the facts and figures around, I suppose, the department's approach to supported living. So I'm asking the witnesses to keep your answers concise and try and keep it on the topic of supported living, because we don't want to engage today in a general discussion around this. We will have an opportunity to come back to this. So we're very keen to get to the facts and figures and statistics. So as you know too well, it's a 10-minute presentation, and then we'll open it up to members. So I'll hand over to yourselves. I'm assuming, Sean, that you're leading.
Absolutely, Chair, and I'll try and take those comments on board and whiz through an opening statement. Firstly, thank you, as always, to the committee for giving us this opportunity to speak to you regarding older people and supported living. You mentioned facts, so if I can start with a few facts. Older people, obviously, in Northern Ireland receive care and support from a broad range of social care services, including residential care, nursing home care and domiciliary care. Since 2008, the number of residential care home packages for older people has decreased by 5%. The number of nursing home packages has increased by 7%, and the number of people receiving domiciliary care has increased 10%. That has to be viewed, obviously, in the context of the changes in demographics. Northern Ireland, like the rest of the UK, has an ageing population. People are living longer than ever before, and a point which committee members have previously made about that is, of course, something to be celebrated. But it is significant in terms of planning. By 2022, we estimate that the population will rise by 11%, and within that, the number of people aged over 65 will increase by approximately 26%, and that represents 344,000 people. And probably the most significant figure in terms of demographics are those of what we call the old, and those are those over 85, and that is anticipated to increase by 50%. Obviously, as I've said, this is something to be celebrated, and I'll not dwell on it, but I think it's important that we set the context that having an older population is something that enriches our community and adds to life in many, many ways, but it does present challenges in terms of providing services. Rates of ill health and disability increase dramatically the older we get. The rate of disability amongst those over aged 85 is 67%, compared with only 5% amongst young adults. Dementia, of course, is one of the most significant issues with an older population growing. 60,000 people are projected to be suffering from the condition by 2051. In addition, the profile of older people requiring care is becoming more complex, with many people now living with chronic conditions. Now, within this context, Transforming Your Care from Vision to Action sets out a number of service changes that are proposed aimed at promoting independence and reducing reliance on traditional institutional care. These include things like falls prevention programmes, reablement programmes, which I know the committee have heard about previously, promoting rehabilitation and independence, and the use of telehealth and telecare programmes for remote monitoring. As set out in the paper that we've provided for you, supported living provides an environment for people who cannot live independently in their own home, but who may not yet require the additional support of residential or nursing home care. The Supported People programme helps fund supported living in Northern Ireland. DSD, the Housing Executive and Health and Social Care all play an important role in the provision of supported living for older people. The Supported People Commissioning Body is chaired by the Housing Executive, but includes representation from the Board, the Regulation Quality and Improvement Authority, and 2 departments, DSD and DHS-PS. And that body, the commissioning body, assesses and prioritises proposals for supported living developments. These proposals are generated by 5 area supporting people partnerships, North, South, Southern, Western, Belfast and South Eastern, and all of those include representation from the relevant trusts. Once a commissioning body approves the scheme, a housing association is then selected to take forward the development. Now, while DSD commits capital funding for the development and revenue funding for housing with support services, such as befriending services or help with security, the Health and Social Care provide the funding for personal care support to tenants on the basis of their assessed needs. Madam Chair, the paper we've provided for you sets out the number of supported living facilities and tenancies for older people, 414 facilities covering some 9,081 tenancies. These represent just over 14% of the overall supporting people budget and just under 60% of supported living units. Obviously, other groups who utilise supported living include learning disability, people with mental health needs and physical disability. At this point, the Department has not established a specific target for supported living for older people. However, an indicator of performance to measure the number of older people living in supported living facilities has been established for the first time within the set of performance indicators that the HSC use. Primarily, our objective is to offer choice to older people, and choice means a range of different options, and supported living needs to be one of those options. Supported living is provided in the context of a range of other services. I'll briefly cover some of those other related services. Domiciliary care, already mentioned it. It was provided to over 25,000 people over the course of a survey week in September 2013. Currently, the Regional Social Care Procurement Group has initiated a project which will undertake a regional audit of domiciliary care. Reablement services, I've also mentioned, aim to maximise a person's capacity for independent living by supporting and enabling people to do things independently rather than simply doing things for people and fostering long-term reliance on care and support. The current position in reablement is that it's been rolled out over 3 of the 5 trusts, and plans are in place for a full rollout across the region. Self-directed support. Now, this aims to give service users even greater choice and control over how their needs are met. And as a first step, it's intended that by March of 2015, 100% of those who are eligible for a social care service, an adult social care service, will be made aware of the amount of money that is set aside to meet their needs. Assistive technology also plays a role, and Northern Ireland has been recognised by the European Innovation Partnership as one of the leading regions in Europe in addressing the health and social care needs of the older population through innovation. For example, the telemonitoring service referred to in your briefing paper provided over 274,000 telehealth monitored patient days and 432,000 telecare monitored patient days in the first 8 months of this financial year. Housing adaptations are also significant, and both our department, the Department of Health and Social Services, and DSD have worked collaboratively on this issue for many years, and have produced a review report which was consulted on from February to May last year. The review report's recommendations, which include closer working and more creative approaches to adaptation, have been welcomed and in the consultation, and officials are currently drafting a final report and an associated action plan to take forward the recommendations. Residential care. Members are of course aware that the strategic implementation plan for TYC indicates that the effect of this broad range of community-based alternatives to residential care will most likely lead to a decline in the demand for places for residential care. And to that end, the HSC has published what we call a programme initiation document on improving services for older people, a new process for consulting, engaging and implementing change, and that was published on the 21st of August. The first of 2 public consultations are currently underway. The first of these relates to the HSC Board's consultation document, Making Choices, Meeting Current and Future Needs of Older People. And Making Choices recognises that in some circumstances it may be better to develop a new supported living facility rather than making piecemeal changes to statutory residential homes. That consultation document sets out 4 criteria which it's proposed will be used to assess the future role and viability of individual statutory residential homes. And the detail of that I think the committee are well aware of, so I won't go through each of those. The consultation runs until the 7th of March 2014, and at the end of the consultation it's hoped to agree final criteria that may be used in future exercises to determine the viability of individual specific homes. In closing, I think it's clear to say that supported living has a role to play in enabling the implementation of service reform proposals. It's an important alternative service to residential care for some people, while for others, other different community-based alternatives such as reablement may be more appropriate. The important thing to stress, however, is that assessed need and service user choice have to remain the key determinants of how and where care supports are met.
Thank you, Sean, for that. And obviously, as I said initially, we do want to focus specifically on the supported living issue. And if I picked you up right, you said that there's now performance indicators within the Health and Social Care Board.
They're being developed, yes.
Okay, but you said there's no target yet for supported housing. Why is that?
Well, I think that the first thing to say is that we don't believe that older people should necessarily live in any one particular setting. The important thing is that people have choice, and that combined with an assessed need should determine where they live. So it's not a case of us having an exact view of saying there must be X number of facilities. The important thing is that there is choice, and supported living should form part of the choice. I think that the indicator that's been developed will give us a better idea of the number of places available, the number of people who are using supported living, and that would give us an indication if we felt we needed a target to create a sufficient marketplace of choice. But currently we don't have a target.
See, I don't think anybody would have any difficulty with choice, or shouldn't have any difficulty with choice. But ultimately we know the demographics, we know the ageing population. You've given the figures yourself in terms of you know, how we move on right up until 2020 and the numbers of the percentage of the population who will be over 80 at that. So we know the projected forecast. Why, therefore, would we not be setting targets that actually address the need?
Well, I think that it is difficult to set a target for choices that people will make in the future, because you don't know what choices people will make, and I think that's one issue. I think that it may well be that we will set targets if the exercise that's underway currently indicates that there isn't sufficient provision. But equally, you don't want to have a situation where you have overcapacity. These facilities are increasingly bespoke and designed to meet particular needs, and you certainly don't want to have a situation where a target is driving you to build facilities which people may not choose to live in. But I'll offer to my colleagues if they have anything they want to add about that process.
Supported housing is only one of the options that we need to develop to meet the needs of older people in the future. It's not the only option available to us. In terms of numbers and targets, we work very closely with the DSD in terms of the funding cycle, 3-year funding cycle. The one that we're in currently, we had many meetings with them at the beginning of that cycle. They asked us what we wanted to develop across a whole range of programmes of care, and we jointly made the submission to the Department for the funding. The current target that the DSD side of the House is working to, I think somewhere in the region of 850 units, but that covers a whole range of programmes and a whole range of geographies as well. I think we're on target to achieve probably 650, 700 of those.
But, well, first of all, I think there's an issue in that about how many of those are actually for older people.
Yeah.
Do you have a figure on that?
Most of the proposals that we put forward in terms of the funding cycle that I'm talking about, most of them were linked to existing residential provision, because most of the projects that we have worked closely with DSD and the Housing Executive on have been the re-provision of statutory residential facilities around the country. I think there have been 10 homes closed over the last 5 years. The majority of those to date have been re-provided for by supported housing facilities.
But we're not honestly saying at this point that of the 414 facilities that we have across the north, with I think it's 10,000 tenancies, that's anywhere near the need or addressing the need. I'm going back to Sean's point in relation to choice. Of course, there should be choice, and that's a must. But there's clearly an identified need here. So I'm just wondering what ratio is being applied to the forecast of the elderly ageing population. There doesn't seem to be one.
Well, I'm not actually sure that those numbers do necessarily indicate that we've got a deficit in provision currently. I'm not aware of significant numbers of people wanting to live in supported living arrangements and not being able to avail of them because of a lack of capacity.
I'm sorry, I suppose my point is that, you know, I suppose you don't need to have to be a statistician to work out if we've got such an increase in our ageing population over the next number of years. We have 414 facilities. Well, surely that's not...
Not necessarily. I mean, I think, and I'll ask colleagues to come in a moment, but I think older people's expectations of where they'll live and how they'll lead their lives are changing fairly significantly, and particularly with the provision of domiciliary care services and reablement services, a lot of people are making the choice to carry on living in their own homes in circumstances which 10 years ago just wasn't available to them. So an increase in population does not clearly equate to a demand for certain types of provision. Pamela, would you like
that's
to come
exactly
in?
the point where I was going to come on to. There has been a significant increase in the investment into domiciliary care. And when you're out in public, I'm sure you find this yourself, that's their voice. Their voice is saying they in the main want to stay at home. It takes you into different fields where you have supported living, whereby people have certain individual needs, that it helps them meet those needs in a more robust way than in their own home. And as we know, it's a continuum. That's where the residential care stroke nursing home care element comes in. But there has been significant change in investment over the last couple of years in domiciliary care.
But I think it's a separate, with respect, I think it's a separate issue. There's a big issue there around investment in domiciliary care and a regional approach to how some of the domiciliary care packages are actually reached or agreed. But I think we need to park that. I mean, we're specifically talking about the facts and figures around supported living, and just in terms of maybe if I just come at this slightly different, the implementation plan for transforming your care. I talked about that improved availability of supported living places. And you referred to it, Sean, in your opening comments, that the demand for places for residential care will decrease. Can you quantify that expected shift?
Well, we know that, I referenced what the most recent decline in demand for residential places has been. I think it's important to realise that I mentioned a range of services, but that doesn't equate to a journey that one individual older person will make through those services. So, for example, one older person may choose to stay at home up until the point where they go into a nursing home, whereas another older person in similar circumstances will make the choice to bridge those journeys by going into supported living, or indeed it won't be a bridge. It may be that they'll end their days in supported living. So an increase in the population can't simply be worked up into a ratio for increases of all of these different types of care. The important point is that we have a range available and people are able to make choices. Now, if we discover that people are not able to make a particular choice because of a shortage of provision, that's at the point at which I think a target comes into play and you stimulate the market in one way or another to make sure that that gap is filled. But that certainly at the moment isn't the situation where we have demand for supported living outstripping
John,
supply.
I think, and what I'm trying to ascertain here is, it seems to me that this is a presumption that this notion of either a decrease in demand for residential care is a view. I'm not hearing anything scientific, and the TYC plan and implementation plan said, due to improved availability of these types of community-based alternatives, it is expected that demand for statutory residential homes will further decline. So I'm asking you, can you quantify that expected shift?
Can I just say, we work very closely with the Housing Executive under the auspices of the Supporting People programme. We have a planned programme of developments across all of the programmes of care on a rolling 3-year basis. As things currently stand, there are 6 proposals in the pipeline for older people developments, amounting to 155 placements. Those are based on submissions that come to the commissioning body from the trusts. They're based on business plans, and those business plans are interrogated by us to make sure that they're based on assessed need.
And I appreciate that, because we're getting facts and figures. You said 150.
155. The 6 proposals, if you'll pardon the pun, 6 concrete proposals that we've been considering at the commissioning body amount to about 155 places. And there are a couple of other slightly more tentative proposals that haven't quite reached business case yet or haven't been approved.
Okay, and because it probably, and I appreciate that, because page 18 of your document talked about the number of intended developments. Is that now the... Because my question, I suppose, reading that was, well, where are the intended developments? What stage are the intended developments at? Where will the intended developments be located? How will they be funded?
Yeah.
Is that the 155?
Yeah.
So they're at various stages of business planning, and they're site-specific, I'm assuming, then, at this point?
Yes, they are.
Yes.
So, therefore, there is some ratio being applied around the needs of the increase in elderly population.
Yeah, I think at this point in the process, the demand is considered at a local level through the area supporting people partnerships. The issue for us with the indicator of performance is whether a central target established by the department might be necessary to drive further expansion, and that's something we'll consider when the indicator of performance starts reporting back to us in terms of data.
Okay, and just finally, because I know there's a number of people that indicated, I suppose what would be very useful, Sean, as this develops, is the specifics around those 155 places, and we're accepting that there's various stages of business cases and planning, but you know, the committee would seek to be informed as that process.
We can get the information from the commissioning body and supply that to you, certainly.
Okay, now I'm just trying to think who has indicated. Mickey, first.
Thanks for the presentation. Sean, you were saying it's to be celebrated that people are living longer, and that's certainly true for older people, but that goes hand in hand with the quality of life, an expectation that people will have an enhanced quality of life rather than having to go into residential. In terms of the supporting people budget, I think we've been told by our research people that for 2012-2013 it was 8.9 million. You know, maybe want some idea what it was in 2013-14 and through to 2016. If you could give us some idea of that, because it wouldn't seem unreasonable to assume that if you're going to put in place a situation where people are going to want to remain at home, then the budget should increase. I mean, that doesn't seem unreasonable in the circumstances. I mean, I sit in the DSD committee, so I'm aware. I'm aware that there's not as close a working relationship, maybe as you have pointed out. For instance, it's not that long ago since the DSD minister stood up in the Assembly and admitted that he had failed to reach his supporting people housing targets. To date, There's been almost 70 million, we're not even at the end of the financial year, handed back. That includes maintenance, etc. But you can build a lot of supported housing and you can build a lot of social housing for £70 million. So there seems to be a disconnect there. And I'm not sure how much the departmental or the interdepartmental relationship is. It seems to me, sitting in both committees, that it's not obvious, and that's the point I would make. So in terms of the budget, it would be useful to try and find that out, because DSD is very heavily, and should be, I'll qualify that by saying should be heavily involved in building houses. And you mentioned choices, and the people would make the choice to stay at home. But if a lot of older people knew what was in store for them in terms of the infrastructure that's provided, they may well make other choices. Because in my experience, and I deal with it daily, and I'm sure we all do, on a constituency level, the infrastructure and the support is simply not there. And, you know, I've been dealing with people for a long time, and we went through customer first and all of that, and the bottom line is it's all about money. Until that's addressed and systems are addressed to put in place proper procedures and proper infrastructure, because to me it's a great principle that people should remain at home, and most people would want to do that, but they can only do that if there's a proper infrastructure and supporting infrastructure to ensure not only that they stay at home, but that their quality of life in doing that is enhanced as they grow older. Because it has been admitted on many occasions people are living longer, but not necessarily more healthily, you know, because of modern medicines and all of that. But people need to be treated as people and not as commodities. And unfortunately, we have moved away from treating people as human beings into commodities, because you can now make money out of them if they live in a residential in the private sector. And that's just a personal observation over many years. So I think that's something that needs to be addressed. But it would be helpful if we could get the budgets through, because 8.9 million isn't really that much in the scheme of things. You know,
specifically, which budget figures are you looking for,
well,
Mickey? Because we can supply you with
supporting people budget for older people. That spend, it was 8.9 million. I think that's the figure we got from our research. Is 8.9, and that was for 2012, 2013. So we'll be looking for 13, 14, 14, 15, 15, 16, if that's possible. I'm sure it is.
It's a housing executive budget, but we can certainly get that information for you.
Well, again, with this close working relationship, there shouldn't be any problem. You think about it.
Can I just come on to clarify on that, Mickey? Because I know that the briefing paper that we've got said that in 2012-13, Trust spent 3.7 million on providing support and supported living settings. So was that all older people in supported living?
Yes,
The
it is.
3.7 million. So is that 3.7 million out of the overall 8 point?
No, that's in addition. The 8.9 is separate. It's the housing executives funding that goes into supported living. The 3.7 is from health and social care trusts.
Okay. So see the 8.3, and sorry, but thank you for letting me on this, because I think it's important. The trust spent 3.7 million 2012-13 on older people in supported living. Is that accurate?
They did, yes.
Okay. Do we have an expected spend for 13-14?
I don't have those figures to hand, but I can check those with finance colleagues when we return to the department. I should also say that the expenditure on supported living for older people is not reported in the same way by each trust. So 3.7 million represents the expenditure of some trusts. Some trusts report the expenditure in supported living through their domiciliary care budget, and that's why I think your research paper also refers to expenditure on domiciliary care on older people, which is around 160 million, I think.
Yeah, but I find it, you know, with respect here, I find it difficult that when we are having an evidence session on supported living, that we can't get access to the budget and projected budget.
As I say, we can certainly check that for you with finance colleagues when we return.
But is that not something, Sean, that the department should bring to us as part of this?
Well, I apologise if you feel we haven't brought you information that you required. We've given you the budget that we've spent, and it is, as my colleague said, a budget which is made up of different components. There is the personal social care component, which the HSC provides. There's also the housing executive budget, which itself has different components. There's both a capital and a housing support component. But if you want us to supply projected figures, we can certainly go back and bring that to
well,
you.
maybe just because I know there's a number of people here. I mean, I think we need to get clarity on the 3.7 million, because we're now hearing that there's different. It goes through different trusts differently, and it might be part of the domiciliary care package. We're talking specifically about supported living here, so I think we need to get the breakdown of that and clarification as to whether that is all for older people in supported living. Then, as Mickey Brady has raised, how much do we expect to spend this year and next on supported living? So if we can get that information, that would be very useful. And apologies, Mickey.
I just want to clarify, Fine, that 8.9 million, that's the figure we got from the research people, is that just for supported housing?
That's my understanding of it, yes.
But yet we've been told by the DSD Minister that the targets have not been reached. So is that something that there's discussion about? I mean, yes. Can we be assured that targets will be reached next year, the year after, whatever? Now, this is obviously separate. This is supported housing, obviously separate from social housing, which is a huge issue in its own right. And again, targets are being failed to be met there. But I mean, in terms of supported housing, I would assume that 8.9 million was not used, or only part of it was used if they failed to reach targets, presumably.
As you've suggested, the development of this model of care depends on different funding streams coming from two departments, from DSD and DHSSPS. Both of those departments are very clear about what they have currently invested in supported housing. Our contribution at this point in time is 3.7 million. If the projects that I have told you about do come to fruition, we have business cases and projected costs in there. If and when those facilities are built and funded from the housing side of the house, then the Trust will be providing the resources and the money to make sure that the care costs are met.
Was it on this?
Yes, just on this specifically. So what's your projections then?
Well, we don't know when exactly all of these facilities are going to actually finally open.
But you should have a ceiling projection vis-à-vis the concept of them, surely.
Yes, we will. I don't have the figures from the composite business cases here.
In a broad generality, then, is it a 10% figure? Is it a 20% figure? What is it?
A 10%
increase.
Increase in the 3.7.
Yeah, I mean, just generally, even give us a ballpark.
If let me see, I think there will be at least two. I think there could be a couple of facilities open in the next 12 months. That's what we've got in front of us here. In terms of what that might add to the health and social care budget, I'm not going to give you a percentage or a figure here today because I wouldn't be confident about standing over it. We can go and find out for you, but I wouldn't be able to give you a figure here today.
Can I again reiterate my apology to the Chair that we don't have, obviously, information that you were hoping to have today, and we'll endeavour to get that to you as quickly as possible in written response.
Go ahead, Fergal. Yeah.
No, I'll just leave it until see how the rest of the evidence proceeds. But
was it on this? Yeah, right.
The point was made about choices earlier on, and my experience is of whether you have supported living accommodation as deemed where there's a mixture of health and a DSD support, that they are full. There are vacancies in sheltered housing, but what's commonly known as supported housing is where there's a bit more supervision. They are full. And as they're full, how is their choice? And in certain areas, what limited supported housing is, such as Liscar and Larne, they're proposed to close with no proposal for replacement, so there will be no choice. How do you say there's a choice?
Well, there are actually vacancies in some supported living facilities currently, and they're available to be filled. But in terms of the planning for any local area, again, I go back to the process that Kevin's described. There is a commissioning process, and it's in each of the Health and Social Care Trust areas, and it identifies the need, commissions, and develops schemes accordingly.
Two new schemes have opened in the last, I think, 12 months. One in Belfast, one in the South Eastern Trust. They're state-of-the-art facilities, and yes, they are taking a little bit of time to fill up. But you don't go and move 30 people all in one day into a new facility. You know, there's a planning and a transition process, and the trusts are very confident that they will fill those facilities in due course. But as regards your own particular geography, and I know you're preoccupied with Larne and the needs of the good people of Larne, and we have been down to Liscarroll to talk to the people and to their carers and their relatives, there are no plans currently in place for any supported housing developments in the Larne Council area.
And are there other areas similarly where there is no choice for supported living?
Well, I've told you already that there are 6 proposals in the pipeline and there are 4 tentative proposals. Those are all significant developments. They're somewhere in the region of 28, 30 places. It takes time. There's a lot of planning involved. It's an extraordinarily complex process. So we're not developing homes in every single council area all at one time. This has to be a planned process. It has to be over a period of time. It's a rolling programme. But the last 2 that opened, I said already, one was in Belfast, one was in the South Eastern Trust. Would like to think that maybe the next geography that might benefit from a good supported housing development could possibly be the Northern. But we can't move on all fronts at the same time.
Okay, Kieran.
Yeah, Chair. You'll be glad to know that I'm after more figures and facts. Again, the committee, if it's going to do its jobs right, it needs to have precise figures, and that's what we're hoping that you'll be able to provide us. And I did see evidence that the department has concrete projections for how many tenancies are needed in the future. The first question is, in your paper, you advise that it's been spoken about there are 414 facilities for older people and nearly 10,000 tenancies. Currently, are there? I think Sean, you mentioned there just a few minutes ago that there are unoccupied places at any of your facilities. If so, how many? Would you know?
No, I don't have the exact figures for the voids that there are currently.
No, but we are aware that housing associations have some concerns about voids within their portfolio of properties. I think the view of housing associations would be certainly that they are not sitting at 100% occupied.
Yeah, you did say, Sean, that
there are some. Yes.
Well, can you get the committee those figures, those that are unoccupied?
We can approach the housing executive. I think it's important to realise these are not health and social care facilities. These are owned by housing associations. Their building has been funded by the housing executive. I mean, we can certainly request the information, but these are not things that we directly run.
Right, okay. The next one is, what is the rate of turnover for places in supported living facilities? Can you give us a figure there?
That would be something we'd also have to check with the housing executive, I think.
Right. How many new tenancies do the department intend to create for older people over the next 3 years? I think you disappointed us by saying you had no target. Sorry?
I think Kevin has already addressed.
But that's not to say that that figure can't be added to as more business cases come through the system or as need is identified at the locality level.
Right, okay.
This is not a static programme. You know, this is not the last figure that we could offer up.
In 10 years' time, how many older people would the department wish to see housed in supporting living?
I think I'd have to come back to my starting point. That depends how many people want to live in supported living. It's not for us to tell people where they're going to live.
Is that what you said at the start of your introduction, that you didn't have targets?
Yes.
For that, and that's the reason you don't have targets, because you don't know what the choice is going to be at that particular time. And is there no way that that can be looked at? Because, I mean, it's something that the committee really needs to find out.
I think that's why we're looking at the indicator to get a baseline as to how many people are making that choice. But ultimately, it is an individual choice. I mean, it's not I mean, if you were to roll the clock back 15 years ago, we could have told you a projection as to how many residential and nursing home beds were going to be in place, and we could have told you how many people would have been in them, because that was the only choice that was available. It's not as exact as that anymore.
Yeah. Okay. Right, Chair, thanks.
Was it on this point, Roy? Yeah, go ahead.
In your paper, you've mentioned this 414 facilities for older people and nearly 10,000 tenancies. Can you tell us how many actual facilities is the Department of Health involved in? And how many tenancies are you involved in? Because there are sheltered housing, which is just the housing executive. So how many is the Department of Health involved in terms of supporting people?
I think, and my colleague will correct me, that the indicator that we've proposed will assist us in giving you that exact answer. We don't have the exact answer at the moment. That's one of the reasons for the development of the new indicator.
I'm astonished that the Department of Health does not know how many supportive living accommodations that they are contributing towards and the number of tenancies.
Yeah, okay. I mean, I share that as well, because even the department was very quick to calculate in terms of residential care, for example, and target 50% of residential care facilities to be closed. So even on the basis of that, thankfully, not now a reality and a proper consultation taking place. But if that had have been a reality, where are those people expected to go if you're saying that you don't have targets? You know, how do you calculate 155 places as fitting a need if we're serious about enabling people to stay at home or to be living in supported housing? I find it really irregular that the department cannot give us those statistics.
In relation to the closure of statutory residential care homes, it wasn't a target. It was said it was thought that possibly up to 50% of statutory homes may close, but each home has to be considered on its own merits. The criteria that are being developed currently to assess whether any individual home will or will not close include the availability of alternative provision in the area. So at a local level, that is done, it's proposed to be done on a planned basis. Currently, not a single home has closed, or could I say will close.
With respect, Sean, and I'm conscious, I don't want to open the debate in residential care, but, you know, 50% was in black and white.
Well,
so therefore, you know, I think the rest of the world looking on would say that as a target. You know, it's not just something that somebody said, I'll put this on paper for no reason, but let's park that, because I know, again, there's a number of people. I think, Roy, do you want to develop your...
In terms of the mix of provision within the Supporting People programme, there could be, or can be, and could be a variety of providers, statutory housing associations and the voluntary sector. Which sector does the department see as having the most potential to provide increased capacity in the near future?
In terms of future developments, again, I would look to Kevin, who's involved in the commissioning, who can identify who are the people who are being identified to bring forward proposals.
Well, the development of most of the facilities in Northern Ireland for older people are developed, as I said earlier on, collaboratively. It's usually the housing association that provides the bricks and mortar, and in most of the older people's developments, it's the trust that provides the staffing. Although the new Moylinny development in East Antrim may involve a voluntary sector provider.
And what are the advantages and disadvantages with each different mix? You know, if you're always going for the the housing associations, what advantage do you see that they have over others? And what other options have you considered in terms of staffing?
The Supporting People model is based, as I said earlier on collaboration between two major government departments and the alignment of funding. We benefit from the fact that the money is provided for the bricks and mortar, state-of-the-art modern facilities, into which people can be appropriately placed following assessment. And then it's up to us, it's our obligation to make sure that they are provided with the appropriate support and care to make sure that they can live there securely. When it works well, it's a very, very good alliance, both in terms of funding and the methodology of support.
Again, I'm aware of Barnholt, for instance, in part of my constituency, and there's many other developments like that. Have you detected a high level of satisfaction with that model elsewhere in Northern Ireland?
Well, I'm not sure if it was contained in the papers that you received, but there actually has been a piece of work done in relation to Barnholt specifically. It's a follow-up piece of work. It's a user satisfaction study. It was very thorough, and the message was very, very positive indeed. But there are other facilities around the country. There's Mullen Mews in the east,
there's Sydenham Court, there's Seven Oaks up in the west. We are getting reports of a high level of resident satisfaction for that model of care.
And are they all sort of housing association-led
Yes, they
development
are.
for
Yes,
the bricks
they
and
are.
mortar, and
Yeah.
then trust provision of support?
Yes, yes.
Okay. Thank you.
Okay, thank you.
And I would like to emphasise that this is a model that, when it works well, it's very, very highly regarded by residents.
I don't think anybody's disputing that. Gordon was next.
Thanks, Chair. Thanks very much for coming in this afternoon. What evidence is there that the private sector are keen to get involved in the provision of, say, retirement villages for folk that probably can manage to buy within the village or perhaps rent within the village? What sort of engagement are you having with the private sector in relation to that?
I was talking to housing executive colleagues a few days ago, and there is currently nowhere in Northern Ireland that could be described as a retirement village per se. But we have been approached, both the housing executive and ourselves have been approached by private developers who were thinking of building this model of care in Northern Ireland. Nobody has yet put their money where their mouth is and developed retirement villages. The model itself in the rest of the UK tends to be in the southeast of England, but it's not a model that's been sort of widely promoted and progressed across the whole of the UK. It tends to be in certain pockets, and I have to say, generally affluent pockets.
That would be the experience internationally as well, that kind of model tends to thrive in areas with high personal net wealth.
Are we doing anything, though, to encourage or incentivise the private developer to come on board? Is there anything being done?
No, because in terms of investment from the private sector in Northern Ireland, and I don't want to digress here, but as part of the wider residential care debate, we have significant overcapacity in terms of both residential and nursing home care in certain parts of Northern Ireland as well. And that's been because private individuals have invested at risk and built facilities. So we actually have an over-provision at this point in time.
But we're thinking more about what you've said about more the retirement village type, where people have an opportunity to rent or, in many cases, purchase a quality development within a quality development somewhere that, there will be space where people will have some amenity and not just be living in a condensed area, but have a similar standard of what they're used to. And I think that needs to be encouraged, surely, and needs to be developed.
Well, I suppose what I said a few minutes ago, I think there are certainly a number of people who have thought about introducing and promoting the model here in Northern Ireland, but I'm quite sure they've done some market intelligence as well. And I certainly would say, I think the indicators at this point in time may be that Northern Ireland might not be ready for this model of provision just yet, or that people aren't prepared in the current housing market, as you probably would appreciate, to take the risk to go to develop that scale and that model of care.
I am aware of some recent new bills in relation to dementia care homes. Have you been engaged with any providers in relation to that, or doing anything further to provide for those with dementia? It's certainly a big issue. We just came from a presentation on it. A number of the members were at it in the Alzheimer's Society, and Megan is very much aware of this problem and something that needs to be addressed and funded. So, is the department going to, again, provide some sort of an incentive to the private sector to engage in this, to provide what I've seen, certainly in North Down, has been a quality development, and is responding to a need, a growing need, sadly, for people suffering from dementia. I do feel there is a role there for the private sector and what has been done to encourage it.
Well, we're working on two fronts. You're absolutely right. Some private sector providers, again, looking at the market and looking at need, have quite rightly identified that dementia is a huge challenge for us, and we have to rise to that challenge. And they have, in some cases, reconfigured their services, sort of point them in the direction of dementia care. And I do know that in North Down and that part of the country, there have been a number of quite significant new developments. And my understanding is that the Trust are working very closely with those developers, because they do see the need for that type of care. But in terms of supported housing as well, some of the more recent projects that have gone into the system under the umbrella of what we're talking about here this afternoon
have been targeted as well to meet the needs of people with dementia. Cedar Court and the South Eastern Trust.
Where's that, sir? In the
Cedar Court, is it in Comber?
Cumber, yeah.
The new facility in the Lower Shankill, Helmsworth. I think the people who planned that and have developed it have tried to ensure that it can rise to meet the needs of people with dementia as well. So the new facilities that have been planned have taken the dementia factor into account. Yes.
These joint ones that you're doing it.
Yes.
The trust
yes.
ones. Yeah.
Now, people with dementia will test this particular model very, very severely because this is premised on the tenancy model and a reasonable degree of independence. It's not. It's the difference between the residential nursing home care where people are very dependent. This is the next tier down. So people with dementia will test this model to destruction. It will be very, very challenging.
Okay, thanks very much.
Thank you.
Thank
Gordon
you, Chair.
Farrell.
Thank you, Chair. TYC states that, and this is probably back to your choice point, about that it's need to ensure that the availability of supported living is more widely known about and promoted. How is that being done, and what's the budget for it?
The lead on TYC.
I think it touches on a few points that we made earlier, and without digressing off supported living supported housing per se, my scribbles have been here that as part of the review coming with the statutory residential review is to look at the needs in each area by geography, and a significant amount of work has already been done and been developed on that. And I think back to your point, Madam Chair, around once you understand the as-is, so what provision we have by people at home with domiciliary care, a clear articulation of who's in supported living, who's in residential care, who's in EMI, etc., across the spectrum, and to layer on that the growth, as we know, in the age of the population, and build in assumptions around anticipated choices that people may make. Because back to Sean's point about people will have choice, and you can but best anticipate where that will take you. That will start to tell us any potential gaps going forward and where that is. It's known in part, and that will be part of the outworking of the consultation around the statutory residential review on what is currently there. But it's taken us more to making sure that as we move and change the model, that we have the building blocks, like getting onto the actual bricks and mortar, in place to make sure that they're there to let people avail of that choice going forward.
How is the supported living aspect being promoted?
I'll defer to my supported living colleagues on. I mean, it is. I think it's back. We have been discussing the point around people's awareness of it, and I think this committee has touched on that as well, in older people understanding where it is, what it's like, the see, feel, touch, to know that it would be an option for them, because I think at the moment not everyone would rise up to understanding.
What evidence can you point to that it is being promoted? Can you tell me about the promotion campaigns and the type of budgets that are attached to them?
Supported living, supported housing campaigns.
I suppose I would come at it from a different direction. As people get to a stage where they need to perhaps move or want to move into a different model or configuration of care, they come into the system that we're talking about in two ways. They can come in through the housing side of the house, in terms of they're moving from one, they want to move and they're not quite sure what the options are. So on the housing side of the house, they may get advice about what's available, and the housing executive colleagues would be promoting it very strongly. We've already talked about, under this umbrella of supported housing, there's a whole spectrum of models of accommodation. In terms of our side of the house, if someone became more frail, more dependent, or experienced disability, and they had to move, they would be talking to their social worker, who would know about the availability of different models of care in that locality or in that area.
So, in that latter category, it's crisis introduces them. So,
no, sometimes it could be advanced planning. If someone is in the early stages of dementia,
can you point to me what the promotion campaigns are, the information flows? Where's the information flows in relation to what they need to know, in advance or at the time?
Assessment.
It's usually on the basis of the assessment.
So at the time and not prior.
Yes.
So there's no promotion campaign.
BSD housing campaign.
In terms of the availability of resources in any given area, information about those resources would be on a trust website, for example. People can access that through the Housing Executive website. That type of information is available, but it doesn't mean that it's promoted on a day-and-daily basis.
Choices and informed choices. What are you doing to inform the choices?
I
I think at the point when someone's having their needs assessed, they sit down with a social worker or a care manager who will take them through the range of options which were available. In the past, those options may have been restricted to residential home or nursing home. Now, when they're taken through those options, they're taken through options which include domiciliary care, reablement, supported living, residential care and nursing home care. So it's not a case of a public awareness campaign where we would spend tens of thousands on an advertising campaign with television or something. It's a case of a relationship between a social worker working with an individual and their family to say, we've assessed your needs, these are your circumstances, these are some of the options which are available to you. That's how the choice is being promoted on an individual basis.
And just for the record, I'm not talking about expensive advertising campaigns. I'm talking about information through the Pensioners' Parliament, through other mechanisms, HNI, etc., etc. What is being done in advance to prepare people for the choices that they will inevitably have to make, and not just at that time?
In relation to supported living, I think individual housing associations all do campaigns where they try and raise awareness about the range of services that they offer, including supported living.
I think.
But are you not doing that?
We do it through the individual assessment and making sure that individuals are made aware of the options that are available to them and they're supported in making a choice.
Okay, you referred to some of the social work stuff, but in other areas, how are people assessed as being suitable? Is it just the social workers, or how are people in general assessed as being suitable for a place in a supported living context?
It will be part of an assessment where an elderly or community care team will be responding either to a request from an individual, a family member. Frequently it's a GP who initiates the process. I mean, Kevin, you have previously managed this area of service. I mean, would that be a fair description?
It goes back to what I said earlier on. People can come into this system in two ways. They can come into the system through the housing route. They may be living in a housing executive house that's too big for them. They may say to the housing officer, this place is too big for me, or I've got a disability, I can't use upstairs anymore. What other options are there? But if the person is in that situation, the housing side of the house will be working very closely with the social worker to do what Sean's talking about, assess their needs and make sure that wherever they end up, that service is appropriately tailored in terms of what they need, both in terms of care support coming in from a trust, for example, and the physical fabric of the building.
This can often be a traumatic period for people who find themselves moving from one side to another. And what we've been talking about is the moving out of. What information is provided, or is any, around information about exiting, in terms of financial advice, potentially, in terms of renting a home, selling a home? Is there anything being done about easing the journey on the exit as opposed to just the entry?
I think they're two sides of the same coin. If someone gets to the stage, either individually or with their family, where they feel the need to move, I would expect both on the housing side of the house and the trust, the health and social care side of the house, it's not just about their physical needs, and that's a very, very important part of it in terms of what Sean's talking about. But any move of this sort has got a financial dimension to it, where you'd be sitting down with people, you'd be assessing their financial means as well, because in some cases people don't have to pay a penny, but in other cases people do have to contribute to their care. So there's the physical, there's the emotional, and there's the financial.
Perhaps I can illustrate that with personal experience. I mean, my mother has now passed away. We went through this process with her, and we were visited by a social worker who, as well as undertaking an assessment, and other people were involved in that, the GP and OT was involved, the social worker talked us through issues about, well, you need to tell us about your money so that we can do a financial assessment. This is the amount of money that you're allowed to retain without having to make a contribution. The legal implications of that were talked through with us. I mean, that was certainly my experience of the process.
Yeah, I don't want to drill down into personal experiences because I've got my own and they weren't good. We've touched on some of them, but what are the usual triggers that result in someone moving into supported living?
It could be somebody getting an early diagnosis of dementia, therefore they're not as able to live on their own, or if they're living with somebody and the person's gone out to work, they're afraid to leave them there. It could be the onset of physical disability. say someone becomes wheelchair bound and they're living in a home, and this is a very basic issue, but where the doorways aren't wide enough, where they don't have an appropriate bathroom. In some cases, obviously, an OT may come to the house, do an assessment, and there may be an adaptation to the property. But if the person feels a need to move out, it could be the disability that triggers that. So,
Can people self-refer?
yes, they can. Yes, they can.
And what sort of amount of people self-refer?
Well, we don't have that figure with us because, to go back to the point that Sean made earlier on, in terms of the numbers that we're talking about here this afternoon, the health and social care system does not have unique responsibility or total oversight of all the entrants to that system. As a matter of fact, most of the facilities that we're talking about this afternoon are the responsibility of the housing executive.
Sorry, I want to interrupt, but is that a feeling? And given the generality of what we're talking about, is there a feeling there?
That we can't identify the number of self-referrers?
Well, not only the amount of self-referrals, there's a lot of other information that you haven't been able to bring to the table here today as well, which concerns me. But in terms of he wasn't talking just about the self-referrals, he's talking about that he doesn't have oversight. Sorry, Kevin, I'm referring to you, of course, that you don't have oversight in that sense in terms of the department. Is that a feeling, a systemic feeling, in terms of how we move some of this forward?
I think it's recognised that the system can work better and the two departments can work closer together. At the beginning of this year, both ministers asked officials to have conversations with each other and to have a series of meetings to identify issues within the planning and the implementation process, and to consider ways forward which would address those. The exchanging of information between the two departments will be one of those issues. We had a meeting last week which included representatives from the housing associations, and there was a helpful discussion around issues from the Health and Social Care Trust perspective, from the Federation of Housing Associations perspective, and from the Housing Executive and DSD's perspective. So I think that forum that has been established will be the means through which we can address many of the issues and many of the improvements that can be made. And there's also a commitment. DSD has made a commitment to review the Supporting People programme by March next year, I think it is. So there's also that mechanism as well, which will also be looking at how the programme works and where improvements can be made going forward.
I think you asked for that to be shared, Chair, is that possible?
Yeah, absolutely. Yeah.
Sorry, I was just going to make the point. I think it's any complex social issue, there's always the dilemma of, do you try and bring it all within the remit of one department or one group, or do you try and approach it on a partnership basis? And you could end up with one massive department doing everything.
Yes, but I'm struck by the graphic at the very start of the TYC document, upon which all of this is predicated, which is the growing population putting increased pressure. And I'm not hearing, with respect, sufficient information here that you're putting enough evidence or enough resource or enough. We're not hearing the information here that you're looking at that in the context of how big it was at the front of the document, if you like. Just specific then, are there currently waiting lists for supported living facilities?
I'm not aware of.
Waiting lists.
Guys, Chair.
I don't really know the numbers.
I mean, with respect, I'm holding my hands up because there's an awful lot of information that we're not getting here today. I'll not make any assumptions around it, Chair. We're just not getting it. It's homework not done. And maybe we should revisit this, Chair.
Yeah, I mean, there's a number of issues I think that members have raised today that haven't been answered, and I do think that it is irregular that we hold an evidence session specifically on this issue and don't have this detail. But I know that Jim has been waiting. Are you finished there?
Well, I had one more, but I'll pass.
No, okay.
I'm sure
Jim
they'll
has been
get
waiting
information.
patiently to get
No, this has been interesting. It has covered some of the points I wish to raise, but I'm just trying to tease out the commitment of the Trust, using that awful Americanism going forward, which I can't think of any other word, but I'll use it anyhow. You've given us some idea of 13-14. What do you see as the commitment to funding through the Trust for the next 3 years for this type of accommodation, sheltered accommodation?
I think it's impossible for me to give a detailed breakdown beyond a comprehensive spending review programme. I think the commitment from the Trust will be to respond to the demand as it presents itself on the basis of assessed need. Certainly Kevin referenced the schemes that are coming online, and that reflects a commitment from the Trust to fund those schemes. And that's the process through which I would see that commitment being taken forward over the next few years.
I think Dean said earlier on, we're coming to the end of a cycle. I think Mickey talked about it as well, in terms of the money that has not been spent in the current cycle. But we're maybe going to address, hopefully, some of the issues that you've raised about the alignment of information. But we're moving into a new phase where we're going to have to develop a new joint bid, look up the road and try to estimate the types of needs and the number of developments that we need to put into the system for the next 3 years. But the horizon that we're working to at the minute, we're not looking much further forward than about 15-16.
Yeah. I'll say that listening to all the questions for what is such a crucial issue, in which, frankly, almost derailed transforming your care because of the whole controversy, there doesn't seem to be much concrete thinking. I would have expected it to have been a sort of very definitive plan as to where we're going, what we wanted to achieve, rather than reacting to proposals by some private entrepreneurs and housing associations. I'm just not content that you've grasped just how difficult an issue this is going to be, because unless the public are reassured that there's definitely going to be proper provision, then the residential home issue will unfortunately come back to bite us again. I'm just wondering why there's a wee bit more definitive answers here.
Most of the actual proposals that are in the programme are actually aligned with the re-provision of statutory residential care in the relevant geographies. So it's not some sort of random choice. Most of the proposals that we've got here are about the straightforward re-provision of residential care facilities. For example, there are plans in the pipeline for Green Island. The home there closed last year. This is a proposal to re-provide and put supported housing in place there. We have concrete plans in the system for Moylinny, which again closed last year. And most of these proposals on the schedule relate to current statutory homes and the re-provision thereof.
I wonder, did you sell that well enough? Because what disappointed me about all of the controversy that erupted around this was that when you dug a bit deeper, there often was very concrete proposals for alternative provision. Now, the one, for instance, in Limavady, there was great controversy over Thackeray, but then I learnt that there was a proposal for a bigger, more modern unit to be built in Limavady, a few miles away. But that didn't seem to be known by the residents, the staff, or local politicians. Have you been doing enough to make it clear to residents that there are very attractive options out there?
I had 2 sessions yesterday with elected members in Ballymena Borough Council and the Northern Group of Councils, and I reiterated John Compton's acknowledgement that the communication maybe at the front end of this process could have been better, could have been significantly better. But we've worked very, very hard at trying to get the broad message back on track, and I think there was quite a bit of acknowledgement yesterday at both of the sessions that I was present at that we have worked quite hard at this. We are communicating the message, I think, a little bit better than we were before, and I think people are starting to learn behind all of the headlines that there were some reasonably well thought through plans in train, in the process of development in different parts of Northern Ireland, that would soak up and address the kind of needs that you've alluded to earlier on.
And were the residents of the existing residential homes and their carers aware of that? Because I listened, obviously, with a mixture of horror and shock about all the media coverage and certain irresponsible BBC journalists who remain utterly nameless, going round residential homes and interviewing very vulnerable old folk. And nowhere in that conversation did they show the slightest indication that they knew there were realistic alternatives to their homes.
Well, I would use 2 examples, and this is the story behind the headlines. In terms of Green Island, and I keep using that example because it's my own geography. The plans were well advanced in relation to Green Island. The residents were on board, they'd been kept in the loop, and they were well briefed. When all this firestorm broke in the media, the people of Green Island were basically keeping their heads down and working very well with the Trust to make sure that it moved towards closure and people were able to move. The same applies in Rathmoyle and Ballycastle. The people in Ballycastle just want to keep on working with the Northern Trust to make the changes that have been proposed. So there were proposals in the pipeline. There were good examples of people working with the Trust. Unfortunately, as I said, the whole firestorm that erupted in April, May last year wasn't helpful. It caused a serious amount of distress.
But to take another argument, I mean, Roy has slipped in a constituency issue, and my own one is Kilkeel, where you've got a very, very good residential home and a planning application in for sheltered accommodation, which would more than replace what Slieve Row presently provides. But that's stuck in the planning system. There's objections from local residents, etc. A commitment that there would be no change to that residential home or any other until the other is up and built, I think would have allayed a lot of fears. There's the concern that some people felt that the residential home would be closed and the alternative wasn't going to be there. Is that a way forward to try and allay the public's concerns?
Well, that's exactly what has been the work that Fionnuala McAndrew has been doing and consulting on the criterion that will be used. Availability and accessibility of alternative services is one of the criteria that she's been consulting on, and so that will now be a criteria. So unless that can be satisfied, suitable availability and accessibility of alternative services, then...
Kilkeel's a good example of what I talked about earlier. It was business cased. The proposal went through the appropriate local mechanisms in the Southern Trust area. And I believe that all of the parties were bought into that concept. The thing that's held this up has been a very technical issue that we in Health and Social Care have no control over. It's around land and the ownership and access.
But Slieve Row was offered up by the Southern Trust with all of its residential homes for closure, and they hadn't even put in the planning application for the alternative. That's what caused a lot of concern.
Well, and I don't want to broaden out this debate, but as part of the revisiting of the residential care issue, we have said to the Trust there needs perhaps to be a more considered look at the possible sequencing and the choices that need to be made in each locality. The idea of and we've moved away from this big thing, the idea of a closure programme, a total closure programme. We've moved away completely from that. That's not what we're consulting on at the minute.
And I think it's clear, the Minister made it very clear, Jim, that he wasn't happy with how some of these things were handled at Trust level, and that's why this new process has been commenced.
Thank you.
Okay, thank you. Okay, folks, thank you for that. I think it is something that we would want to return to. Certainly, from my perspective, and I think it's shared today, we're not getting any sense that there's a strategic approach to this issue that is actually based on the needs of the population. And I think it is frustrating, Sean, that we can't be told today, for example, how many of the 414 facilities are actually funded by health. Equally, we can't be told today of the 3.2 million budget, of the breakdown of that, of how much of that is directed towards supported living. We also haven't been told how 155 places will actually meet the demand that is there, and even how those calculations are taking place. So I would expect going forward, Sean, that this is something that the committee have obviously taken very seriously, and I would suggest to you that it's a key component of transforming your care, and therefore requires, at the very least, accurate data and accurate statistics, and equally a strategic plan on how this is taken forward, and we just don't hear that today. So I have no doubt that we will be writing back to yourselves with a number of questions and queries, and we will await the answers to those, but I expect that we will be having a further engagement around it.
Thank you, Chair. You know I appear before this committee not infrequently, and although it's frequently a robust exchange, I would always endeavour to have the information that I would anticipate that the committee would require available. Occasionally we have to say that we'll come back to you with a written response. Today, obviously, the number of issues that we have to do that on is greater than I'm happy with, and clearly that you're happy with. However, I would say it probably reflects the complexity of this issue, in that this is not solely the preserve of of the department or indeed the board or trusts. This is an issue that involves several partners, different government departments, housing associations and what have you, but we will certainly do our utmost to respond to your request for the information.
I accept that, but the Department of Health has a key role in this in relation to transforming your care, and therefore at a very basic level should be in a position to come to a committee and tell us a budget. So I'll leave it at that without opening up the discussion again, but we look forward to getting the information back from yourselves and continuing the conversation. So thank you for your time today.
Thank you, Chair.
Members, moving on to item 6, which is the Forward Work Programme. I'm asking members to note that, which is on page 22. I want to advise members that the visit to the Royal Emergency Department is likely to be arranged for the 19th of March. Evidence sessions with the Belfast Trust and the Royal College of Nurses on these issues will be arranged for the following week, just to make members aware of that. And again, because of our focus on emergency department issues, this means, and rightly means, that some of our evidence sessions on the review of transforming your care and supported living options for older people will take place after Easter, as will the visits to some of the facilities as part of that. Again, I'm just bringing that to members' attention. I want to refer members to pages 17 and 22 of the table papers, and the purpose of the two proposed statutory rules is to amend the employee contribution rates in the Firefighters Pension Scheme 2007 and the new Firefighters Pension Scheme Order of NI 2007. The rate of employees' contributions will be based on pensionable pay bands and will be increased by between 0.3% at the lowest level and 2% for those earning more than $120,000 per year. The Fire Brigades Union have...
Our papers say 1.4.
We'll clarify that just. The papers 1.4 for...
1.4% for those earning more than 120,000 per year.
Okay, I have 2.0 in this, but I'll come back to you. We'll just clarify it, yeah. The Fire Brigade Union have objected to the increases. However, it has been stressed that if the increases aren't made, the cost will come out of the block grant and would cost the executive 2 to 3 million, 2.3 million, I think that is actually, for every month of delay. Bringing that to, can you clarify?
Yeah, it's between 0.3% to 2%.
Just 2%.
Right, that's right. Maybe that's for the other. There's two separate. Chair, there are two separate SL1s. One for the Firefighters Pension Scheme and one for the new Firefighter Scheme, and seem to have slightly different figures.
Okay. Is that clarified, Fergal? Okay. Okay, members, item 7 is another proposed statutory rule, which is the Firefighters Pension Scheme Amendment Order 2014. Can I ask just a member's consent for the Department to proceed with this statutory rule? Thank you. Item 8 is a proposed statutory rule, the new Firefighters Pension Scheme Amendment Order 2014. Again, are members content for the Department to proceed?
Great.
Item 9 is a proposed statutory rule, which is the Health and Personal Social Services Superannuation Health and Social Care Pension Scheme Regulations 2014. I want to refer members to page 27 of the tabled papers. The purpose of this proposed statutory rule is to increase contribution rates for members of the HSC pension scheme from the 1st of April 2014. This is year 3 of a 3-year process. The BMA has objected to this increase. Again, however, if the increases are not made, the cost will come out of the block grant and would cost executive $2.3 million for every month of delay. So can I ask if members are content for the Department to proceed with the statutory rule?
Great.
Item 10 as a proposed statutory rule is the recovery of health service charges amounts amendment regulations 2014. It's on page 33 of the tabled papers. Again, the purpose of this rule is to provide for inflationary uplifts from April 2014 to the tariff levels provided for the recovery of charges and compensation cases. The committee deals with this statutory rule on an annual basis. So again, are the committee content, or members content?
Under compensation recovery, where people get benefits, that used to be recovered, and except there was a maximum of 2,500 below which they didn't recover. But people lost huge amount of money out of the compensation. Then it was passed on to the insurance companies. So I'm just wondering, could we get clarification if that's going to be the case, or does a person actually have to pay their health charges out of their compensation? Because for most cases where there's accidents, it would be insurance. So, and it's not clear in that.
Is that something we can clarify? Certainly. Is it something that, because this is an annual?
Chair, I do have a memory that we clarified something similar last year, but I would need to double check it because I can't.
Okay, we can clarify that.
the
You have enough
detail.
of that. Okay. Okay. Item 11 is matters arising. I'm asking members to note 7.1 on page 26. Item 7.2 on page 27 is a response from the Minister regarding paediatric cardiac care. The Minister has advised that the elective surgery in Belfast commenced on the 17th of February 2014. The surgery is being carried out by Dublin-based surgeons under a service level agreement. Members will also note that the Minister made a written statement on Monday providing final details of the team who will carry out an assessment of the need for cardiac services on an all-Ireland basis. The assessment will be completed by June 2014. Are members at this stage content to note?
Great.
Okay. Referring members to a response from the Minister on page 12 of the table papers, which provides additional information following the evidence session on the guidance on the termination of pregnancy on the 29th of January 2014. The committee, if members are minded, had asked for clarification on whether the Chief Medical Officer and or the Chief Nursing Officer had formally approved the final version of the draft guidance, which went out for public consultation in 2013. Members will see from the response that the Minister doesn't give a direct answer to this question. The Minister has also made the point that it is for him to decide on the content of the guidance after considering the evidence and various views put forward. So, do members at this point have any views on the points raised?
Great.
Referring members to a response from the Minister on page 14 of the table papers on the independent review as a result of the report on procurement issues in the Northern Trust. The review will be completed in 46 weeks and will consider the potential for any disciplinary action. Are members content to note? Item 12 is correspondence. Item 8.1 on page 28 is a letter from the Minister advising that he is seeking executive agreement to bring forward a bill which would ban the sale of electronic cigarettes to people under the age of 18. England and Wales are planning to bring in similar legislation, as is the South. The Minister intends to include the provisions under the Health Miscellaneous Provisions Bill, which will cover a number of issues. The draft bill will go out to public consultation. So, do members wish to write back to the Minister supporting the proposal and asking that he conveys his support to executive colleagues? Great, thank you. I'm asking members to note items 8.2 to 8.4 on pages 34 to 43. Item 8.5 on page 44 is a letter from the Association of the British Pharmaceutical Industry seeking to attend the committee event on the 2nd of April. The committee has previously taken the view that given the limited time it has available for meeting groups, it would focus on those in the statutory, voluntary and community sectors rather than organisations that do represent commercial organisations. So I'm suggesting we write back to the organisation suggesting that it provides a written brief of any issues it wishes the committee to give its attention to. Item 8.6 on page 45 is a copy of a letter from Mitchell House Special School to the Minister regarding the provision of services to the Belfast Trust. Again, are members content to advise the school that it does not become involved in individual cases and would suggest that they contact local MLAs for support? Do members have any other business?
Do we provide them with the appropriate contacts so that we're facilitating that?
Yes.
Yeah, that's fine.
Yeah, Chair. Once again, we've heard of the crisis in the Royal Victoria and the A&E. I don't know, is there anything that more the committee can do to speed up the remedies that's required to get that sorted out? I mean, I think this last one, while there hasn't been as much publicity, it has just been is equally chaotic, is what I understand, in the accident and emergency in the Royal.
Well, I think what we are doing is we've requested an update from the meeting that the Minister had with the Royal College of Nursing last Wednesday. We're awaiting that response because I would suggest that there have been recommendations that were put on the table there, even around the interim processes that need to come into line. We're also, as I'd outlined, going to conduct a visit to meet with the staff and the Belfast Trust and visit the Royal to engage directly there. So I think we need to get a sense of what the recommendations coming from the professionals were from last Wednesday and then reflect on those. And I suppose we need to track also the review that's taken place and its timeline and recommendations coming from it.
Right. The other one is, Madam Chair, you've heard me raise at this committee about the Muckamore and the resettlement. Again, I'm very disturbed. I don't know any member reads the Antrim Guardian around the table, but there's another bad report on the front page, and I think, I mean, I can give you this, and perhaps the committee can chase up. I did have a meeting with the senior officials from Muckamore, and I was very impressed by what they're doing. But yet again, this appears on the front page of the Antrim Guardian, and readers will see that there's a lot of stuff, according to that report, that is unacceptable. And is there something that we can do to clarify, or at least get the department to refute the allegations in the front page of the Antrim Guardian?
I think it's no doubt it's another important issue, but again, I think this is down to individuals, MLAs. I mean, I would suggest, without telling you, Kieran, how to do your job, I suggest it may be a written question to the Minister on it. There may be a question to the department on it, but I think it's something that individual MLAs need to track and trace themselves.
Yeah, but I mean, it is very worrying because we all have in our constituencies people in Muckamore, and we certainly are very concerned about how...
No, absolutely accept that. I'm not taking away from the issue, but again, I think it's just in terms of protocol here that we need to be mindful. I know Roy had...
It's a different issue.
Okay, yeah, okay. Kieran.
It's actually going back to a visit to the Royal. I'm just conscious that, for instance, in terms of consultants who were willing to speak out, it wasn't any of the local consultants that felt free to do so. It was a recent consultant who had moved to Glasgow. So I think it's worthwhile, it's right that we go there, but I would ask that the staff should be trying to assess how we can ensure that we will be able to hear the unrestricted views of the staff and to look at what mechanisms might have to be put in place to enable that to happen, because staff members may feel constricted in what they can say to us.
Yeah, and I think that point was made that this can't be about putting any undue pressure or more pressure on staff in that situation. So we'd certainly look at mechanisms there. Fergal, do you indicate?
No, I was just going to just add that, of course, there was another escalation Sunday over Monday, and obviously there's conflicting reports around the extent of that, and it's just something to add in terms of our evidence gathering.
Okay, members, thank you for that. Date and time of next meeting is the 12th of March at 2 p.m. in the Senate. Thank you.